We're live. All right, we're going to start the next session in just 2 minutes. I hope you've enjoyed your lunch, and just 2-minute warning. I should also invite our panelists up for this discussion. So our panelists and moderators, if you could make your way up while we finish our lunch. You're the moderator. Yeah, you're the moderator.
Where do you want to? What's good for you guys?
Sit here. You and Osama want to be over here?
I want to be able to see their.
Oh, right.
Yes. You're gonna do introductions? So maybe I'll stand there. So I can see the titles.
I'll introduce you too, and then you can come up.
Yeah, I know. I mean, I finally got a room to change it. You know. Yeah, I didn't get a room till last night. So. They never called me.
We're missing one panelist.
Yeah, I didn't get it.
It's Rich from Mike. Do you see Rich?
I saw him.
Oh, here he's coming. He's coming.
But that was the real me. This is. I like this. Thank you.
Whatever. I don't know if there's.
All right. Post lunch. This won't put you to sleep. That's great. It'll be a great panel. I'm excited for this panel. I'll introduce our moderators for the session. First, to my left here, Dr. Osama Gaber. You've seen him up here already. Surgeon from Houston Methodist, Houston, Texas, and then Sean Van Slyke, Executive Director of Sierra Dona Services in Sacramento. This session and this afternoon, we're pivoting to talk about the professional perspective on metrics. We're going to hear both from the organ procurement organization side of the equation as well as the transplant program side. So without further ado, I'll turn it to Sean. You're going to introduce.
Great. Thanks, John. So as John alluded to, we're now going to focus and shift gears a little bit to what the transplant professionals, what information is important to them to help in their decision making. Can we get the next slide? Do I do that? There we go, perfect. So we have an esteemed panel here of our expert colleagues. We'll call them the professional miracle makers. So we'll hear from the group here. I think we'll be starting, I don't know if there's any particular order, but we'll start left to right with Jan Finn, who's the CEO of Midwest Transplant Network and also the immediate past president for the Association of Organ Procurement Organizations. Followed by Rick Haas, the president and CEO for Gift of Life Donor Program in Philadelphia. Dr. Rich Formica, who's the professor of medicine and surgery department at Yale University. Followed by James Pittman, assistant vice president of transplant services, HCA Healthcare, And then wrapping it up is Dr. Lloyd Ratner, the Director of Renal and Pancreatic Transplantation, Department of Surgery, Columbia University. So I'll turn this over to Jan.
Sure.
Great.
Thank you. Thanks to the committee and this group that's worked on this really well. I appreciate being here. As Sean introduced me, I am one of the several CEOs in the room. And I think for the organ procurement organizations, we take a deep responsibility for the work that we do. It's very important that we are in charge of allocating organs, but more importantly, how we get there is through donor families and through the work that we do in hospitals to ensure that referrals happen. One of the key measurements that we've always had is that, and our relationship with hospitals and with donor families to actually get them to the place where they are comfortable saying yes, so that we can provide organs to the very, very needy recipients that are waiting on us and depend on us. So as Sean said also, I'm the past president for the Association of Organ Procurement Organizations, and we've worked over the last year or two, actually since 2019, to really develop some metrics that we believe would strongly enforce the work that we're doing, but also represent that back to the community in a way that's meaningful. I'm proud to say that my OPO, and I know that Rick's is also a Tier 1 OPO. That probably doesn't mean a lot to those of you in the room that don't understand that new metric that was thrown at us in 2019. But what it means is that we're doing some things right, but we also are the ones that want to learn how to do things better, and we do that through data. So whenever the NASEM report came out, I think that that was really a very important consideration. One of the charges from the NASEM report I take very seriously, and that is the national dashboard and developing goals surrounding that. So recommendation number 1 from NASEM was to develop a national performance goals. And that's not just for OPOs. That's for transplant centers, that's for hospitals, and OPOs, and how together we get to that to make sure that we're making the improvements that are necessary. So I know that we have a breakout after this, and I wanted to throw out a few ideas of things you could talk about, metrics that might be very beneficial to all of us in thinking about us as a system. We need to get our information from a variety of sources. We already are responsible for submitting data to a variety of different sources. The SRTR gets information from us, but these standardized metrics are things that have changed over time. We've always looked at donors. We've looked at transplants. And as Rio said yesterday, you know, it's really not about just the OPO when we look at transplants. It's about the system. There has to be someone, I love John Snyder's analogy of the football that's being thrown, and there has to be a receiver. So we are concerned as a system about not just looking at the number of donors and the number of transplants, but also the transplant center acceptance rates. We're plagued by making sure that we offer appropriately so that we allocate every organ that's possible from a donor family to continue their legacy, but we have to have someone to receive that. So when offer acceptance rates dip, or whenever we can't find the right recipient or transplant center, it is concerning to us. So I would just say that in the past couple of years, there have been many critical pieces mentioned about organ procurement organizations and the lack of our effectiveness. There is a wide variety in our performance. We recognize that. But we also recognize that through data, we're able to improve. And that's really what this conference is about, is to develop those types of metrics that would improve us. There's 5-fold variation in our acceptance rates in pursuit of DCDs, but over the last 5 or 15 years, we've grown from 600 or so DCDs across the country to over 4,000. So we do make improvements. We make changes based on data. So when we think about the task force that AOPO enacted in 2020, we wanted to look at some of the things that would really roll up to a standardized metric for performance, to track this performance and to improve our results. We all know that a ventilator referral is what we need to make sure that a donation happens. A deceased organ donor needs to be on a ventilator or have been on a ventilator for us to be able to evaluate that progress moving forward. So we talked about such things as vented organ referrals, coming up with agreed upon metrics, which we did in November of 21. We decided that we could all agree on what an organ donor was, what a productive organ donor was, a transplanted organ, but also some of the more, I think, finite characteristics that we really want to consider in metrics, and that's family conversations, whether the family said yes or whether they said no. We need to determine if the patient was eligible, suitable for us to pursue, whether that's over the phone or it's face-to-face to them. So we're counting those as conversations, and whether that resulted in a donor or not from first person. So a recovered organ donor, I think we all can agree upon that. But I would challenge you with some of these thoughts for how can we continue to develop metrics that will be improvement goals for us. What if the regulations for hospitals included not only the number of referrals, but the way that they honor first-person authorization? Across the country, we know that first-person authorization should be honored each and every time. It is not, either through hospital disagreement or wanting to make sure that they are collaborating with that donor family or potential family. But if they were measured on that, and if we are held to those types of things, could we provide more opportunities for transplantation? Could transplant centers be held to the fact that they have to operate 24/7? Could hospitals make sure that they're managing donors 24/7 and allowing us to have options for surgery? If these are the types of metrics that we're looking at, it takes a very granular view of the hospitals and their performance, as well as the transplant centers and the OPOs. We know that discard rates is a very hot topic and one that we could improve upon, but we need more information to be able to look at that and really come to close eyes about refusal codes and how we can make sure that those discarded organs, if they are transplantable, they are transplanted. So in the OPO world, those of you in the room that don't work in an OPO may not realize that we have an obligation to report ourselves to CMS if we are not able to provide a surgeon to recover organs, if there is a usable organ that is not recovered. So we prepare for that. We are not at 100% capacity every day, and we rely on each other. So looking at some of the ways that we can improve our focus and always have someone available, not only to recover the organs, but also if we need to delay surgery, to make sure that that surgeon is available, or that surgical recovery specialist who is trained by our own staff is able to do those recoveries. I would also ask that the SRTR, and this is my bold ask for the day, that we come up with a way to have AOPOs define definitions that we identified and agreed upon in 21, to work through those with the National Quality Forum and really vet those definitions through what we have already decided will work, but through a consensus-based evaluation. And I believe that's one of the biggest things that SRTR could help us with. But also really thinking about some other things that we could measure and should measure. Should we be looking at the effectiveness of the DCD programs in the OPOs and in the transplant centers? Should we look at the OPOs in their aggressive pursuit of COVID-positive donors, HIV donors, hepatitis-positive donors, all of these types of patients that we know are the next frontier, certainly the beyond 65 or the older donors, and the difficulty in not only getting those referrals, that I think we've accomplished through the OPOs, but making sure that we maximize that and work with the transplant centers to get them placed. So finally, I would just say that we are in the business of saving lives. We need to make sure that we do that with data transparency and effectiveness so that we can be a big part of making sure that these organs are made available to the needy recipients when their time for that organ offer comes. We want to make sure that the transplant centers are ready to accept those, and we want to do everything we can with data to make sure that they accept that organ as we're offering it and be grateful for the opportunity to save a life.
All right, thanks, Jan. Hi, I'm Rick Haas. I'm the President and CEO at Gift of Life, and I'm going to take a little bit of a different perspective this afternoon. We've talked a lot over the last couple of days, particularly as it relates on the OPO side, to trying to get to that denominator of potential. Because if you get to that, then you can start having real performance metrics, whether it be referral rate, donation rate, authorization rate, and all of those things are really what I would call the blocking and tackling of the work that an OPO does, to do more donors and to provide more organs for transplants, really to be good stewards of the gift. But one of the things that I think often gets overlooked is how we go about and do that work efficiently. And I know I've had individual conversations with folks in the room over the last 2 days, and I think our system is designed perfectly to discard 29% of the organs that we're recovering. It's perfectly designed to do that. And so if we want to start beginning to have a conversation about, well, how do we, I forget, I think it was Alan, redesign a system to decrease the number of discards, what data do we need to help inform us of that? And it goes along that transplant continuum. So I'm really just going to try to focus from the time the OPO gets authorization, assuming that's done, and then what happens afterwards and what data should we be collecting to measure the efficiency of our system. We heard from donor families in our breakout. They want to know how long the process takes, right? That was a big question that they had. And so we actually looked at this, and we found that in 2008, the average time on a brain-dead donor from the time that patient was pronounced brain-dead until actual organs were recovered, cross-clamp time, that was roughly median in the United States about 24 hours. It took about 24 hours to go through that process. That has climbed now to, in 2020, to be well over 50 hours. So the process has doubled in that amount of time. The other thing that we looked at was the OPO variability across that. So some OPOs now are within that low of 19 hours to the high of 76 hours median, right? And so there's a lot of variability in there. And so we really have to look at, well, what's causing it? You know, and are we getting more organs because of it? Is the yield different? And our preliminary analysis is there wasn't, with increased time, an increased yield or an increased observed versus expected. So that time, what were we doing? And how much time should it take? I was sitting next to Ken Andrioni yesterday, and he got a kidney offer that was at 19 hours. Creatinine of 1, a 32-year-old donor, but I think it was a very surgically complex, would have been a very surgically complex donor. What if he would have gotten that offer pre-recovery or an hour after cross-clamp? Would the outcome of that kidney be different than discarded or not accepted? And I think we have to think about that on how we redesign the system. A lot of time I think we spend looking at just the offer and acceptance and that dynamic, and a lot of it goes on in that organ allocation band. But there are things that are upstream that we should be measuring, from the donor evaluation, the donor management, the organ allocation process, OR scheduling, transportation. Each one of these different segments of that donation process should have different measures and metrics surrounding it so that we can better understand as we pull different levers of allocation or different levers in the regulatory space, what effect that may have on the overall efficiency. I think we've been adding and adding and adding and not really understanding what effect on efficiency these things may have. Simple things as transportation, right? In the continuous distribution model, efficiency is that last lever that you can pull left or right to look at how it changes. But really that surrogate right now in efficiency is really distance traveled or cold ischemic time, right? And so that is not a huge measure of efficiency. It doesn't count that we need now 2 sets of pilots because they timed out because we had a delay in the OR or other different, you know, we can't even characterize, if you asked us, how do organs travel? We don't really collect the information. We don't know if it's air charter, we don't know if it's courier, we don't know if it's with the OPO. Where is that process breaking down? So I think you can look through all that spectrum of the donation process and develop different metrics to define that efficiency. And it goes back for me to what Rio said yesterday, starting off. We really need a goal. Before we talk about the metrics behind the efficiency, we need a goal. You know, what should our goal regarding efficiency be? How long should this process take? What is the expectation? And as we do that, we can be more than clear on how we communicate with donor hospitals. How efficient is it there at their hospital? I mean, if we have these metrics for our system, we can then make sure it strides down to that donor hospital level. So I don't know, Sean, how much time I have left, but I think our model is designed right now to perfectly get us what we're getting, and we have to start thinking about the different data points we need to measure efficiency in the process of donation and transplant. Thank you.
So my name is Rich Formica. I think many of you in the audience know me through my extracurricular activities. And in those roles, I try very hard to keep in mind my fiduciary responsibility and make decisions based upon what's best for the system, et cetera. But I have a job that pays my bills, and that job is to be a doctor. And then what that means for me is I take service 10 to 12 weeks a year. Depending on staffing, I do 140 to 160 clinic sessions. I chair the medical review board. Some people call that recipient review committee. I chair our donor advocacy committee, et cetera. So my comments are going to be from the point of view of metrics, not process or decision-making tools. And they're going to be from the perspective of somebody who's trying to navigate this system. And from that perspective, I've heard a lot of conversations about organ discards and on and off the list. And I think it's important as we think about metrics, you need to have the frame of reference also of the people that are the physicians. So I want to offer this to everybody to think about while we're talking about metrics. When I use the word I, by the way, it would be my surgical colleagues at Yale, because we all work hand in hand. I don't get incentivized for building a small list. I don't get incentivized for saying no to a donor. I don't get incentivized for not doing a transplant, right? What we try to do is we try to make decisions that we think are the best medical decisions, because that's really what our responsibility is as doctors, right? Our responsibility is to make good medical decisions for the people who present to us and ask for our help. So as we think about metrics that try to get us one place, to get to what Lloyd's always said, know what you want, ultimately you want your doctors to still be doctors, because that's what we do. And you don't want to create an environment where I think I should do this, but I'm being pushed to do that. So in that spirit, let me tell you what I want, okay? I want a metric that is discrete, it's actionable, and it's timely, and I can use it to improve patient care, improve the transplant program, and help me navigate the regulatory and institutional environment that I have to get through. And I'm going to break those down in a moment. But let me tell you what I don't want, okay? I don't want a metric that's going to be taken out of context, used by a third party for something it wasn't constructed or validated to do, and for some end that I have no stake in. I don't want somebody to take a metric that I'm trying to use to determine how I'm managing patients post-transplant and then link it to the hospital's ability to get paid, and therefore I've got a well-meaning but very pressured administrator telling me I've got to do something different, because that wasn't the way that metric was designed. So my metrics would include all facets of transplant care, from evaluation, listing, wait list management, which I don't think is getting enough attention, peri-transplant and post-transplant. I want all those. They've got to be discrete, so there's got to be a true understanding of what the positive outcome is. It can't be ambiguous, where it could result in both. I want them only to measure one aspect of the process that we're looking at, so that if there's something wrong, I can know what I have to fix, right? I don't want to be like, oh, is it the nursing staff? Is it the physician staff? Is it the people answering the telephones? I want to know exactly what the problem is. And that any metric that is indicating underperformance, I can then use to improve the performance of the program. I don't want to have ambiguity. They have to be timely. So to the extent possible, it's not a backwards-looking metric. It is identifying things in real time so that I can respond to it prior to driving the bus off the road, right? So it's got to be timely. They have to identify patient safety issues that can either be used to make patient care better or make the experience better, and that would be time to referral, time to once referred, time to evaluation, time to listing, et cetera, that I can improve the experience. I want to be able to improve the program. Yearly at Yale, we have a talk, the program we think we are and the program we actually are, right? So we think we use a lot of DCD kidneys. In fact, we didn't until we realized it, and then we did it. So it has to be something that can be used to improve your program. And in that regard, I think we could have length of stay, we could have post-transplant monitoring for viral infections. There's a whole host of things you could do. They have to help me navigate the environment that I'm forced into. So I need to know what's going on in the program so that I can respond prior to getting the letter from UNOS, right? If we're gonna have a mistake or we have a problem, but I've already identified the problem, I've fixed the problem, and we've already got data showing the fixes happen because I've served on the MPSC for 4 years. By the time the MPSC is involved, most programs that are taking their job seriously, they know the problem, they know the fix, and they've probably got 3 or 4 months of data to show us it's already better. Well, that's a very easy review to do. Thank you very much. Process improvement has worked. We'll talk to you later. That's the way I want that to work. It would be nice if these metrics would help me define work and benchmark my efforts against other programs, because I can't get resources. But if I can prove that what we're doing is being under-resourced, and I can do that in a quantifiable way, then I can get more nurses, I can get more pharmacy technicians, I can get whatever I need, but I have to have the data, and without the data, I'm just another guy with a hunch, so I don't get any traction. And finally, I really think they should be focusing on how are you gonna build quality in your program, and I think quality is more quantitative or more qualitative than quantitative, and I think as a community, we should determine what is quality. Is quality the number of transplants? Is it the number of different types of organs used? Is it whatever? But we should all determine what we think quality to be and then record that and then use that for making our programs better. So that's what I would like.
Great. Good afternoon, everyone. I'm Lloyd Ratner. I've been doing this for over 30 years, since I had hair, before some of the people in this room probably were born. I have strong opinions on this. You've heard some of them. I think Rich and I share a lot of the opinions. You've heard from Rio. You heard from Dave Axelrod yesterday a whole bunch of things that we weren't supposed to talk about. I've never been good about coloring within the lines, so I apologize if I talk about some things that we're not supposed to. I think this is a really critical juncture, and to quote my favorite philosopher, Yogi Berra, when you come to a fork in the road, take it. And I think there are a lot of different ways that we could go. So I congratulate John and the organizers, the other organizers of this meeting, for doing this. You know, we work in this complex transplant ecosystem of donor hospitals, regulatory agencies, OPOs, transplant centers, payers, and the OPTN, which has the allocation. Rick's talked about the issues in terms of logistics and efficiency. So take all of that into account. My goal is I would like to see as many people who need a transplant be able to benefit from a transplant, okay? And we're falling way short on that. We heard Ben Hippen talk about, he thought that was the ultimate goal we ought to have. Now, I think the core of what we as transplant surgeons want is we really want to improve patient care. And again, I think we look at metrics as the report card by which we get graded, and as Rich said, by which we could utilize to improve our performance and improve patient care. So that has to be, the metrics that we get have to be goal directed. So that there has to be a goal. We have to be able to say, okay, the metrics speak to that goal. They're not just a number to be checked and not a number, you know, devoid of being within the whole system. They need to be clinically relevant, okay? And I'll give you an example in just a minute about a non-clinically relevant metric. They have to not only allow but also encourage innovation, because the only way we're going to improve patient care is being able to innovate. And they need to, like Rich said, they need to be actionable, okay? If it's just a number and I can't do something with that number, and like Rick said, then it's really useless. So what does actionable mean? Well, it needs to be understandable. it needs to be predictable. So right now, when we're looking at 1 and 3 year patient graft survival, we don't know what that benchmark is going to be beforehand because it's calculated retrospectively and we're graded retrospectively. Like I said, it needs to be clinically relevant. So a difference of, 1% to me in a large system is not really clinically relevant for any individual patient. And it needs to be temporally appropriate so that we're not being graded on things that happened 5 years ago or 10 years ago, which are no longer relevant. Our practices have changed and all. So I was hoping to be able to show you some slides, but I have a picture, a graph here that shows my center's 1 and 3 year survivals over 7 reporting periods. And in those 7 reporting periods, we got flagged for patient survival twice, okay? The difference between all those reporting periods was 1.3%. And in fact, one of the reporting periods, we got flagged for having a 97.1% survival. Another reporting period, we did not get flagged for having a 96.9% survival. So how do we do anything with that? That doesn't help me. It doesn't help me take better care of the patients. All it is, it's been used as a cudgel against us. Now, goal-directed, what are some of the goals that we could have? Well, I would say, if I had to pick a few goals, and again, take the low-hanging fruit, take things that are the most immediate and most impactful, I would say we need to increase access to transplantation, and we need to make transplantation possible for as many people that could benefit. Second, we need to improve allocation efficiency with logistics being part of that. Third, we need to be able to increase the organ supply by a number of methods. We want to decrease the organ discards. We want to increase deceased donation. And one of the things we haven't talked about very much and has almost been a non-entity is increased living donation. And there are huge disparities in terms of living donation across the country. And then finally, we want to improve graft survival. So like Dixon Kaufman has talked about, 1 organ for life, so we don't have to be retransplanting people. So those are some of the goals I think are relatively low-hanging fruit. I think everyone could get around and gain consensus about. Now, when we talk about the allocation efficiency, one of the things that we're seeing is that the allocation is going, it goes to the first person, second person, third person, keeps on going down the list. And then by the time it gets to someone who could utilize that organ, it has too much cold time or it's been taken too long. So I would say that without utility, equity is moot. And I know that's probably an unpopular thing to say, but I think it's the reality of the system. I think there are some important features that we haven't talked about, and these are that metrics need to have. Like I said, they need to be clinically relevant. We need to assess what our data sources are, and we need to utilize alternative sources rather than just what the centers are reporting. There are other systems out there that have large amounts of data that we could tap into. And then it's very important what our comparators are, okay? Are we compared national versus local? Because maybe the national comparator is not germane to being able to improve my program. Are we looking at ourselves over time? So are we improving rather than comparing us to another program? Are we looking at transplant versus alternative therapies like transplant versus dialysis or things like that? Next is, once we've figured out what the comparators, what are the thresholds we want to choose for determining whether a program is performing adequately or not? And I would say if we're looking at a 1% difference or a 1.3% difference in outcomes, I think that is not a clinically relevant threshold, and it's too tight and it's not helpful. Then what are the consequences? We have a carrot or stick approach, okay? right now we only have a stick approach. There's no, it's only a punitive system. You don't get rewarded for doing well in any way, shape, or form. And then finally, public versus private reporting. And that speaks to the consequences as well. So if everything's out there for everybody, as my friend Osama Gaber said, if it's out there for other people to use, they'll use it against us. And then importantly, we're not going to get things right the first time. This needs to be an iterative process, which leads me to my last quote, another quote from Yogi Berra, my favorite philosopher. In theory, there is no difference between theory and practice. In practice, there is. So whatever we dream up, we need to keep that iterative approach and keep improving our metrics and respond to the needs at the time. Thank you.
Well, good afternoon, everybody. My name is James Pittman. I work for HCA Healthcare, and I have the privilege of supporting 11 transplant programs within our organization. And so we have very small programs, medium-sized programs, large programs. We have kidney-only programs. We have multi-organ programs, thoracic, abdominal only, et cetera. And, so I approach this a very similar manner, and I agree with all of my colleagues' comments. But I want to focus on a few things. I think one thing that I look at first and foremost is access to care. We're in a lot of community-based hospitals, which I think is a benefit to the patients that we serve. And so we want to make sure that we are absolutely capitalizing on providing access to those patients. And so where's the void in the data? Well, we don't necessarily have what was mentioned earlier. We don't have like the number of evals, the number of referrals, et cetera. We don't have good data around that. Now, my hospitals will tell you that they do, but I'll tell you that that data is inconsistent across when I compare against other hospitals. So having that standardized, of course, has already been discussed. I think that's important. But I think what's more important, and what the NASM report has suggested, and many of us have suggested over these first 2 days, is what is the need, right? And so understanding what the denominator is. So how many patients should we be adding to the wait list? Like, should I have an expected additions to the wait list based off of, a merger of data that is available? So why can't we take USRDS data or HIE data now that we have the health information exchanges for pulmonary, for heart, for thoracic, for liver, and then create definitions that would then define a population of which we would think would be an eligible referral for a transplant, so that we can at least get the beginning of a soft number as to what should we be looking at. I think that's probably even easier to do when you talk about merging USRDS data, looking at zip code data, FIPS code data, and marrying that up with actual additions to the transplant. I think another thing that I feel like when I look at program performance, right, I also look at, of course, all the things that we already look at, right, like organ offer acceptance, waitlist management, et cetera, et cetera. But we don't have a robust data set around living donation, right? And in fact, I think that's because I think people think like living donation is passive almost. Like people don't like, oh, well, it's a living donor, and so if the living donor actually opportunity presents, then, then great for them. But the reality is that programs that work hard at performing live kidney donor transplant perform live kidney donor transplant. Programs that work hard at performing paired exchange do that because they work hard at doing that. And I would dare say that that is actually a standard of care now. So if you have a donor that comes forward that's ABO incompatible and is an eligible donor, and you say, oh, sorry, we can't do you here, and you do nothing with that donor and recipient pair, I think that's a problem, right? And so we need to have, I think, better awareness of the performance around living donation. And the SRTR data, when you look at outcomes, when you look at time to transplant, it doesn't consider live kidney donation, for example. And sorry to be a little bit kidney-centric on this part, but this is a big, I think, a big miss, and one in which we can really kind of help hopefully expand upon, because as mentioned earlier, as Dr. Ratner said, there's very little difference between 1%, 2% outcomes, but there's a huge difference between the duration at which a program transplants based off of access to live kidney donor transplant or access to paired exchange transplant. You know, you can get into like the behavioral economics piece of it with organ offer acceptances, and again, I find that all fascinating as well, and that's something that we really want to stay focused on. But when we talk about, you know, what is the data that's needed, I really feel like we should spend some time talking about the living donation data. We need that for our payers too, because for the programs that are doing living donation, like we all know that a preemptive live kidney donor transplant is by far the best treatment modality. And in my opinion, I believe most people are eligible for a transplant. Now, I have to qualify that by saying that it depends at what point in their journey, right? So some might only be eligible preemptively. Some might only have a 6-month window of time. But in general, most people would be eligible for a transplant at some point. It's just we have to match up the timing of that transplant with their greatest health state. So looking at ways in which we can report on this and then share this with the payers so that the payers can, again, begin to see the value, because everybody's stuck on 1-year outcomes survival as like the gold standard of, determining a transplant program's performance. And no one's looking at the actual impact and the hard work that our surgeons, our transplant administrators, our nephrologists are all putting in, our donors, our living donor who are partners in this, and our recipients who are partners in this as well, all coming to the table to solve a problem, right? That is, like, I think one of the greatest examples of everybody having skin in the game and everybody contributing to solve the problem, and then having that become more well known across the enterprise, or sorry, the organization, so that in the community, so that we can benchmark against one another. Thank you.
So thank you very much. It was a very, very rich conversation. I don't know how much time we have to cover it, but we'll take some questions. But maybe I think, Jim's, what you talked about, we should actually have a metric of how much it takes to get some living donor transplants done based on the insurance company they have. Because I think that that's actually a very important determinant of that, and we should discuss that in the session, coming up. But go ahead.
Excellent panel, and I just wanted to expand on James' comment there in that there is an initiative underway, the Living Donor Collective, which is collecting data very separate from the OPTN, and our goal there is to start upstream and collect information on candidates and then follow all the way through to a lifetime registry. But the important point about that is by collecting information on candidates, we can address a number of the questions that you've raised in terms of which donor candidates make it forward and so forth. Dr. Kosiski and I have been working on this for a number of years. One of the barriers is getting program participation. This is a HRSA-funded effort, but it is voluntary, and so I would love to see a statement coming out of this project really emphasizing the importance of this and getting more center buy-in. Thank you.
Thank you. Dr. Davis.
Dr. Davis.
That's what I said.
Oh, okay. So I heard Rich's comment that you don't get incentivized for having a smaller wait list or for doing less transplants. But it feels like I hear that in other comments when I hear that there's, cudgels and retribution and payer contracts that we need to be concerned about with star ratings and such like that, and the professional prestige that we haven't heard a lot about if your ratings aren't as good at your hospital. perhaps your peers don't look at you the same way. So there's a great deal that we're hearing as patients. Let me say I, because we are not a monolith, right? Patients are all different. But for me, it sounds like doing less complex patients and not listing patients who you expect to be difficult is actually incentivized through the system.
Let me take that for you. That's an important point, right? So I think there's nuances to that, right? So the first nuance is, as transplanters, that's what we do, right? So you don't go through your day thinking, how can I do less? Your default position is usually, how can I do more? I want to do more. That's what you want to do. But I think the notion that somehow there's, I mean, as a group, we take care of very sick patients. Patients who we say are healthy, in quotation marks, are actually quite complex and quite ill. So this notion that as a program director, and let's round the number off, I get 650 referrals per year. Just please look at this individual. That sort of idea that somehow out of that 650, I heard the word cherry picking before, which I do not like. I don't think that's a good word, but it seems to resonate, so people know what I'm talking about. But this notion that somehow I could cherry pick a list that would allow me to do even a comparable number of transplants and account for all the other variables that happen. A patient dies in a car accident, they become too sick. Like, that takes like if you do 80 transplants a year, deceased donor, 100 deceased donor transplants a year, you probably have to be adding 170, 180 patients to your list per year just to maintain steady state, right? So this notion that I could somehow build a transplant program around these ultra-selected, less sick patients, that's one of those things people talk about, but like when you sit in clinic and you see these folks that are coming to you for help, it is very rare that you have the 35-year-old patient with PKD who took the afternoon off to come to clinic. It's not the reality that I experience. So what I say that is, the goal is not to limit the list. The goal is to try to look at patients and say, who do I think we can make better with the transplant? And who do I think, at the, what we can offer at Yale, can we actually offer that to? And I will often refer patients to Lloyd, because I'll say, I think he can give you a better chance than I can do it. But that notion that we're incentivized to not do things, I don't know. Lloyd, you want to comment?
Well, let me put a little different spin on it. That, regardless of what we like to think, it is a punitive system. And I've sat in the room where the CEO of the hospital said, you got flagged, and the board of trustees wants to see someone's heads roll, so I'm firing this person and this person. I've sat in that room, okay? And I think a lot of us have sat in that room who are on the front lines. So you don't get any credit for going out on a limb with a patient, even if it's the right thing to do for them. You only get penalized if you don't. So it's a matter of you get penalized for commission, but not for omission. And I think that's what a lot of us are facing, and and we're also put in an ethically untenable position where we either do what's right for the particular patient or what's right for the program, and they're not necessarily always the same thing.
But Ernest, let me just make one last statement. So I learned from Karen today. It was actually a very valuable conversation. She helped me rethink about a metric versus a decision tool. And I think that's what we have to be clear on, right? So if you're saying to me, we want to construct a decision tool, so a patient who I may not accept, but another program may accept, but that tool is not going to be used for anything other than for a patient to say, I should not waste my time at Yale, I should go to Columbia right away. I support that completely. If you're talking about a metric that's going to grade a program based upon its performance, you want to make sure that you're not making physicians and surgeons do things that they don't feel are medically appropriate, like putting people on a list who many people in this room could look at the same 72-year-old diabetic patient and come to a well-reasoned, but different opinion as to whether or not that patient should be listed. And that's, I think, the distinction, metric versus decision tools for patients. And that's what I was trying to make the point of.
And I want to say that if you come sit in some of those medical review boards that we have, there's sometimes the discussion about one patient lasts an hour. And that's not because the patient is easy, right? It's because it's complex. And it's complex because the vascular system is this, and the lung is that, and the heart is that, and this is this. So the idea that you're going to go through this review board and you come out either listed or not this easy, I mean, it's not that easy. There are different sets of experiences and expertise in different places. I may have the best cardiologist in the world. He may have the best intensive care person in the world. He can do somebody who's critically ill. I can do somebody who has really bad heart disease. It's different. And the idea that it's like the same across, I think is not right. I just want to take us to something else before we forget, which is what James said. No, I'm letting you answer, but I think this whole context of the risk and taking the risk would change completely. And I applaud James for bringing this up. If the majority of the patients were seen preemptively. After 8 years of being on dialysis, right, a lot of these patients that were transplantable then may not be transplantable now. And I think the system needs to move there.
When the system gets there, right? At this point, so many of us crash in that
No, I'm not.
that's not
but we're
helpful
planning
right
for
now.
the future.
But for the first two retorts, I think they were both cogent, yet a bit personal, as opposed to system-wide. If you just have a cutoff, an arbitrary cutoff like BMI, I'm going to keep talking about BMI, but if you already have the arbitrary cutoff, we never get a chance, right? And you're only doing that because you don't want the outcomes to look a certain way. But I'm not going to belabor that point. Just as long as I've been advocating within this space, I've heard a lot of people say we need to bring information in from different places, different systems, but I haven't heard, why haven't we done that yet? What's holding us back from that? I'll take my seat.
Well, this is an important, you made another great point. So these are not debating Ernest, who I sit by in board meetings and such, but like the reason, so the BMI cutoff, just using that as an example, well, we're told, we're required to have listing criteria. Okay. But listing criteria can't be, well, on Tuesdays I'm good with this one, and on Wednesdays I'm good with that one. So then you have to have criteria. And then when you have criteria, if you're going to deviate from your criteria, you either don't, because then you can be called to task for why this person and not that person, or you have to have some really good argument, right? So we do robotic cases on patients whose BMIs exceed our BMI criteria, but their vasculature is okay. Okay, now I've got a reasoned medical decision why I'm not following my criteria. And I think that was my point. When we start making metrics, we want to be aware of how they impact the way we as doctors then make our decisions. And I think we could probably belabor that, and I won't do that anymore. But
Hi, I'm Kevin Fowler. I'm going to speak right now from Teleris industry perspective. But, you know, Dr. Radner, I just want to amplify your comments and being honest about the punitive aspect, because that's what I see from my standpoint from the last 15 years. And I would just ask this community to think about that, how that's also impacting other innovation. And so if what I see from my point of view, we're working with companies like Teleris, CSL Berry, and others are trying to bring innovation to the marketplace. That punitive approach to transplant centers creates an environment that doesn't want to, you know, it makes innovation much more difficult. And, you know, my concern is there's lots of innovation that you are all aware of, right, potentially to come to this marketplace. But the question is, I have my concerns what's ever going to make it to the market because of how the system has been. And so I would just want to bring up that point, that there's a potential to save lives, make lives better, but I sometimes really wonder whether that's ever going to happen because of the punitive culture that you said. And I appreciate you being honest rather than beating around the bush. Thanks.
Yeah, thank you. And I think there are ways we could get around what we have now, but I think we have to recognize it remains a problem now. And I'll just to quote Adam Bingaman, who worked with James down there. Adam said, you know, if if I'm living in a 95% world, I can't transplant the 90% patient. And I think that's really, really, really sad. And the same thing, we know with any type of innovation, there's a learning curve. There's, and there are going to be failures with any experiments. So we have to be able to take those hits. And right now, if there's a 1% difference in outcomes and you get flagged and people get fired at your program, you can't take those hits so readily. And you can't cohort the difficult to treat patients, the patients with difficult problems, which aren't included in the risk adjustment. And that's how we're going to make progress, is by cohorting patients in a center that has a special interest in that particular problem. And we can't do that right now.
And I think it's just great to hear your perspective. I just like to hear more of this, to hear your side of the story, so that we could figure out how to better to work with you. So thanks.
Thank you.
Hey, so
Hi.
it's me, Rio. Just a couple things. I'm a transplant professional to help run a transplant program, et cetera. There are ways to live in a 90% world. If that's your expected outcome and you reach it, great. Because that's about proper risk adjustment more than anything else. You're saying that, so if you risk adjust something, you can take all the risk you want as it's risk adjusted for. And if you get that expected outcome, you're exactly where you should be. So some people should achieve 98% and they achieve 95%. That's not good for those patients. 1 in 20 are losing those grafts. But a 90% program that actually does expected 85%, they're doing much better. So I actually push back a little bit and have to really talk about risk adjustment. Having said that, metrics are created for certain purposes and goals. And sometimes those goals are not met if you share the metrics in a different way, or if people are given access to it or use it in a different fashion. That doesn't make that metric bad. It means that it's used in a different way or in an improper fashion. So I have to ask or challenge people to think about what a metric itself is not good or bad in itself. It's how it's used. If it's used in a punitive fashion when it's not designed to be that way, that's not a proper use of the metric. And having said that, getting back to the OPO side, let's say we had a goal of reducing discards, for example, as a goal, and how do we set metrics to achieve that goal? Well, we know that certain behaviors actually promote discards, literally promote discards. We know that transplant centers that participate in late declines or have late reallocations, what a good formula to result in a late decline resulting in a nightmare for allocation and resulting in a discard. We've asked for years that be tracked, that centers that participate in late declines be tracked. That should be a metric, right? Would you agree with that? There are also OPOs that don't make a primary offer of a kidney until after cross-clamp as a practice. They never allocate a kidney as a primary offer till after cross-clamp. Should that be tolerated in the OPO community? I'm just asking a rhetorical question, but these are things that are, to me, low-hanging fruit. And we don't collect the data, so I'm asking for the next breakout group to really think about how we get to the bottom of certain goals, design the metrics that'll fix that goal, because we know that those are the things that we know promote discards. So if you really want to be serious about getting rid of discards, well, create metrics that get rid of that incentive or get rid of that practice. So thanks. I'm just preempting the next.
Just a quick comment, Rio, on that, and I agree. And I think we've never really looked at efficiency and set goals around it. I think we have, however, talked a lot that it's all happening in that allocation. And I think it may even happen more upstream. Did you work the donor up properly? Did you get all the diagnostics done in a way up front? Was it completed? Was it a fully vetted offer that you made, so that the center isn't looking and requesting for 5 different things when they're trying to handle 20 other offers? And it's just a lot easier behaviorally just to say, you know what, it's not worth that work and effort. I'm going to get another offer tomorrow, and I'm not going to put in. So what are those variables? And we're not, and you're right, we're not collecting it. But I think until we have a goal on what is that efficiency beyond just discard or organ allocation time, but how are we measuring efficiency and along that entire spectrum? I think there's a lot of work to be done.
If I could just have one comment about the risk adjustment that Rio brought up. I agree with you, Rio, but there are some things that are so infrequent they will never appear in the risk adjustment, no matter how good it gets. And I think there are a lot of flaws with the risk adjustment, not because we don't want it to be better, but it's just, you know, statistically it's difficult to do.
So I just wanted to add one quick thing, and Rich brought it up. You know, I think there's the assumption that once people are on the list, they're going to be transplanted. And I think there's a lot of variability on waitlist management and who's active and who's getting transplanted and who's accepting organs for those folks. And I think it's not something that we spend as much time as we could and should. And I think from a patient transparency standpoint, how we do that, because I think the only thing worse than being told you can't be listed is being told you're listed and then never having somebody accept an organ for you. And we've all seen that. Now, the flip side of it is we've got to fix this allocation inefficiency issue. You're absolutely right. We're throwing our good organs away because we're not getting them in too late. So,
Thank you, Dan.
thanks.
Hi, my name's Merle. I'm a heart recipient from Kansas City area. And I wanted to address the risk adjustment factor we're talking about. But I operate from a position of assumption that the healthcare providers and the hospital that I'm at are going to operate with ethics in every interaction with me. You know, unless I have reason to believe otherwise. So that's presumed ethical behavior on the part of the providers, I think. I don't think most patients come at it from some other perspective. So I don't think we really need to look at a lot of those kind of things. Those are more for the industry folks. From a patient perspective, you know, I don't really know about those things, but I want to address specifically on high-risk candidates and high-risk donors, those kind of things. I think to incentivize programs to take chances on those and to get that experience, like you mentioned, Dr. Gaber, about how do we train surgeons on these if people won't do these except for at certain facilities. I think you should look at the concept of exclusionary criteria like we use in patient safety indicators in healthcare. There's patient safety indicators, yes, a patient that has post-operative kidney injury requiring dialysis. The fact that they're on dialysis post-operation is a fact, and it would be a PSI except for they were in shock when they were admitted. So it's excluded, it doesn't count. And I think some type of correlation like that would maybe be appropriate so that you in fact have incentivized the programs to take those high-risk candidates, to try the high-risk donors, and that's going to accelerate learning and maybe even some new techniques for those types of patients that end up being effective. So unless we're willing to take those chances on patients, and myself, for example, I know I was a risk when they did my surgery with a BMI of 40, and they did it, and they proved that it worked. But in general, there's lots of other conditions that may in fact be worth, you know, saying, as a professional panel, saying, well, these conditions, yes, should be excluded from the metrics. We don't count these mortalities against the program because they were trying to advance care and improve the life of that patient. That's all. Thank you.
And I think, thank you so much. This is an excellent remark, really, because when you sit in front of a patient and you tell him he's high risk and he can't have a heart transplant, or he's high risk, he can't have a liver transplant, that means that his chances of survival are zero, right? I mean, it ends up the conversation. But I do think that the idea of safe zones for research, safe zones for outcomes, you know, safe zones for modifications, for the risk, I think all of these things beyond just the regular statistical risk adjustment are ideas that the system should really consider to allow some patients to get through the system in an easier way and be successful. Like he was, I think, a BMI of 40 and a heart transplant, I would say, you know, that's an amazing thing that happened, and congratulations. I mean, it's fantastic, but it shows that it works. So thank you so much. I think our time is up, and I got the hook, so thank you so much. I appreciate it.
All right, I'm going to invite Dr. Hirose up. He's going to just give us a few brief comments as we go into our afternoon breakouts. I hope you enjoyed the morning breakouts. The afternoon breakouts we're dividing up by more of the professional topics. We have an OPO session. We have a transplant professional session. We have sessions dedicated to insurance providers and regulators. And as you've heard up here, that regulatory concern is a large concern. So I'll turn it to Rio, and you're going to give us a few pointers as we move into our breakouts. And I think we will still try to wrap those breakout groups at 4 to give you some time to have a break before coming back to this next session.
Maybe we
we're already into the session, we should basically make our way to our breakout sessions, maybe take a 5-minute break at most. But the point of the afternoon breakout sessions is, in fact, you are divided up into what's important to OPOs, what's important to transplant professionals, what's important to payers, and what's important to regulators. Now, in your room, you'll have a bunch of folks that aren't part of those groups, but try to put yourself in other people's shoes again, as we try to do when we are providers, and put yourself in the shoes of patients, and think about what is important, not necessarily how. Again, we don't want to necessarily jump the gun and get to actual metrics, but really think about you heard a lot of what's important to the professionals, transplant programs, OPOs, patients who actually do pay for it, and people who not only just regulate, but provide oversight and make sure that there's patient safety issues that are addressed. And how should that stuff be monitored? And what metrics are actually important to be shared and not? So those are the things that you should think about in your breakout groups. We're going to ask the moderators again to come up afterwards and assign one moderator from each group to summarize in a very brief fashion. But again, appreciate all the engagement, and patients have something to say about what payers and regulators should think about as well. So just because you're not one of those professionals doesn't mean you can't say what the professionals or payers and regulators should be paying attention to. So thank you very much.
And just one quick reminder for those on the virtual platform that it might take 5 minutes or so for our virtual moderators to get the session fired up, so just have your patience. And yeah, the map of where your rooms are here, those should be in your program materials, which you're at your day 2 afternoon breakout. So we'll see you back here for the report back.